Aloha and good evening. I'm Mark Alexander, Executive Director of the Hawaii Medical Association. It's my pleasure to welcome all of you here and thank you for joining us for this Conversations at HMA. This is a program which features discussions with physicians and other healthcare professionals and thought leaders in the healthcare arena. For this edition, we have a special roundtable that will address Senate Concurrent Resolution 34, passed earlier this year, which requests, quote, the Hawaii Medical Association and the Hawaii Psychiatric Medical Association to convene a roundtable to establish medical protocols to ensure that an individual's thyroid function is tested before psychotropic medications for mental illness are prescribed, unquote. Before introducing our presenter, I want to review the format for our program. We'll begin with a presentation by Dr. Gerald Busch, and I will introduce him formally in a few moments for about 30 minutes. After his presentation, we'll move to a Q&A part of this program. Those here in the room are invited to ask questions directly to Dr. Busch so that we can have an active engagement, kind of simulated roundtable. Those participating via the Zoom webinar, we invite you to submit questions and comments through the Zoom Q&A function, which is available. Please type in your questions, comments, suggestions, ideas throughout, and we will feature as many as possible after the presentation and initial Q&A in the room. You also see we have some index cards and pens there. In case people prefer to write down questions, you can do so and give them to either Mark Conching or myself, and we'll try to feature them. We will end the formal program at 6 p.m. Now, we want to hear from you, so please email us at info@hawaiimedicalassociation.org, or you can always contact us via our website, hawaiimedicalassociation.org. Now it's my pleasure to introduce our speaker. Dr. Gerald Busch is board certified by the American Board of Psychiatry and Neurology and Psychiatry and Child Adolescent Psychiatry, and has added qualifications in addiction psychiatry and forensic psychiatry. He is certified by the American Board of Preventive Medicine in addiction medicine. We're now pleased to welcome Dr. Gerald Busch. Get your slides ready.
Thank you, Mark. It's a real honor and a privilege to be able to speak with you and to provide information about this topic to you tonight. So I appreciate the invitation and the opportunity. This is regarding SCR 34/2024, Senate Concurrent Resolution, which is to ensure thyroid function testing is done prior to the administration of psychotropic medications. This will be to address the role of the MD or DO in safeguarding patient health. So the objective of the talk is to discuss the request of the Senate. And the request specifically was for the HMA and so-called HPMA, or Hawaii Psychiatric Medical Association, to ensure that thyroid testing is conducted prior to prescribing medicine for psychiatric disorders. This is not a talk about the thyroid gland, only insofar as it relates to the topic. I'm not going to be going into it. I'm not an endocrinologist, but I have some familiarity with it from having been in medical school and done some internal medicine training. But just to say, it's a gland, as you can see in this picture, located in the front base of your neck. When you're in medical school, you learn how to palpate or examine this gland. It's responsible for regulating metabolism. So if it is giving out too much thyroid hormone, your metabolism speeds up too much. If it's not giving out enough, your metabolism slows down. And there are signs and symptoms of both. And there's a picture of the main thyroid hormone. There's two. There's T3 and T4, but T4 is the one that has the most activity. So this is not a chemistry situation either. This is not a chemistry talk, but rather a talk where I just want to give you some idea of the breadth and depth of knowledge that's required to understand and implement this entire endeavor. So it extends from having a knowledge of organic chemistry to understand these hormones, anatomy, physiology, pathology. The people that are the real experts in the thyroid gland are endocrinologists. So the thyroid system, as I mentioned, is secretes two hormones, T3 and T4. This is regulated by the thyroid gland, but the pituitary gland secretes a hormone called thyroid stimulating hormone that regulates the thyroid. So this is relevant to know in terms of having some idea of thyroid tests, laboratory tests for thyroid. So in testing for thyroid, the typical elements of the test include measuring the T3 and T4, the two hormones, and the thyroid stimulating hormone, or TSH. So there's another test called thyroid hormone binding globulin that's also sometimes necessary to measure. And then one last little twist on the whole picture is that the pituitary gland, the gland that secretes the TSH, is regulated by the hypothalamus, which is sort of a central region in your brain that's critically important for regulating some of our most basic biological functions. And it secretes a hormone called thyroid hormone releasing hormone. So now you've had your basic education and some of the elements for what's involved in understanding the thyroid. Why is thyroid testing important? Now, the first thing to know is that thyroid testing alone is not sufficient to diagnose depression or thyroid disease. Thyroid hormone can help screen, but thyroid disease or thyroid problems are diagnosed by a human being, by a clinician that takes these different factors into consideration. So people with clinical training might recognize that someone who's complaining of coarse skin or coarsening of their skin and coarse hair and brittle fingernails and feeling tired and worn down and other symptoms may have low thyroid, and that may trigger them to look for thyroid tests. There's a variety of different presentations, and this is why it's so important for someone who has clinical training, someone who's experienced and has actually seen people who have thyroid diseases. So that would be most medical students and people who've had internships. Thyroid testing, though, is an essential component of a comprehensive evaluation. So thyroid testing is the laboratory part, but the doctor part is taking the history, conducting a review of systems for the general practitioner, physician that's doing the physical exam to actually do an examination of the thyroid and other organs like the skin that might be affected by low thyroid. Thyroid testing, though, can help identify treatable thyroid conditions that might be contributing to or even causing depression. And when appropriately tested, the thyroid labs can lead to targeted treatments, which may potentially alleviate or get rid of depression. Now, only about 1% of people with depression have low thyroid, but if thyroid testing is not done, we might miss those. So all psychiatric residents, physicians who do a residency training program in psychiatry are taught to obtain a battery of lab tests. Thyroid disease is one of a number of medical illnesses that can cause depression. So they all have to be screened for. Someone may have adrenal insufficiency or other physical health problems that can cause depression, or other conditions can cause depression. Treating those conditions doesn't necessarily mean the person might not need antidepressant medicines. But one of the most terrible and embarrassing things for a psychiatrist to find out is that someone they're treating who they've explained that everything has to do with their brain and mind is actually caused by another medical problem. It's a terrible thing to happen, and that's something psychiatrists don't like to have happen to them. They want to do a thorough and comprehensive evaluation. So thyroid function testing matters. Thyroid disorders can mimic or exacerbate psychiatric symptoms. If someone has a high thyroid level, they can appear very excitable, emotional, and appear to have mania, the bipolar disorder with mood elevation. If someone has a low thyroid, they may come in and appear to have what psychiatrists call psychomotor retardation, whereas in fact, they're just moving slowly because their metabolism is so low, they're not able to function properly. And those people would need treatment with thyroid hormone. For people with elevated thyroid conditions, there's other types of treatments depending on the cause of the thyroid disease. But once someone develops those sorts of thyroid diseases that are more serious, they need to see an endocrinologist who can properly treat and manage those conditions. Thyroid function and mental health. So hypothyroidism, hypo means low, can lead to symptoms like fatigue, depressed mood, and even cognitive slowing or cognitive impairment. When you ask the person a question, it may take them time to come up with an answer. They may have trouble with their thinking. And this can also be a symptom of depression, cognitive slowing. Hyperthyroidism may cause anxiety, restlessness, mood swings. So again, both can masquerade as psychiatric disorders, especially to someone who may not be looking for or screening for those other physical health conditions. Now, there's another thyroid condition called subclinical thyroid dysfunction, and this is where the thyroid disease is not obvious. The person may not be showing other signs of low thyroid, but their thyroid is still not functioning properly and can cause depression. Prescribing medications, psychotropic medications. All patients who are prescribed antidepressants or antipsychotics must receive medical screening. So that would pretty much include most psychiatric medications. The person should be screened either if it's a child or teenager by their pediatrician or by their internist or family doctor, or they should be referred for a physical examination. Lack of clinical review and lab screening by a physician, a medical doctor, can lead to overtreatment or mismanagement of mental health conditions. So SCR 34 seeks to help encourage or request the establishment of protocols so that we can disseminate this and have a certain standard in our community so that patient health and safety can be safeguarded, to help physicians, clinicians be able to be reminded and have the awareness that thyroid testing is crucial in conjunction with diagnosing and treating depression. The implication is that is to ensure that psychiatric symptoms are not the result of some other medical condition. Now, like I say, even if 1 in 100 people have low thyroid as the cause of their depression, it's still critical to catch those cases, or you're not providing proper service to those patients. Medical doctors, physicians, MDs, DOs have a special role in this process. They're uniquely qualified to evaluate thyroid because of their level of clinical experience. First of all, to understand that thyroid hormone itself and how it works, you have to have had chemistry and organic chemistry to understand its mechanism of action. You have to have physiology and endocrinology. So there's a number of basic information sources that come together and giving a foundation just for understanding how things work. Then physicians have experience with patients who have actual thyroid disease. So I could sit here today, if you've never seen an elephant, and give you a description, a vivid verbal description of an elephant. But all it takes is one visit to the zoo and seeing an elephant before you have a visceral appreciation of that elephant. So I'm not trying to compare medical disorders to animals at the zoo, but in a way, once you see and experience these cases, you won't forget. I still remember the first case of hypothyroidism I saw as a third-year medical student. It has a great impression on you because all of a sudden, all these things you've been learning from books take on a new meaning and reality. So psychiatrists, as MDs and DOs, are trained to consider medical comorbidities, that just means other medical diseases, for diagnosing and treating mental illnesses. Now, just a footnote here about psychologists and prescribing. So medical doctors and DOs possess comprehensive training in internal medicine, endocrinology, and pharmacology. Psychologists are trained in psychotherapy and behavioral interventions, not in medical diagnostics or pharmacologic management. So not to get into the whole issue about psychologists and should or shouldn't prescribe medications, but I think SCR 34 gives a pretty good idea of what could be the problem of having someone who does not have a background of clinical experience in medical situations all of a sudden be in a position where they're prescribing, not necessarily understanding what the labs mean or any of the clinical signs or symptoms or causes or pathology. Medical doctors have quite a bit of training in this regard. They have to have had a year of chemistry, a year of organic chemistry and biology, biochemistry and physics and math in order just to meet the basic requirements of getting into medical school. 4 years of medical school and then 3 to 7 years of residency where they focus on pharmacology, physiology, and medical diagnosis. Psychologists at the same time go to graduate school and focus on psychotherapy, counseling, and behavioral sciences. So SCR, so this Senate concurrent resolution sheds light on some of the foundational problems of asking or allowing psychologists to prescribe medications. So medical doctors are essential for the SCR 34 protocol implementation. Only MDs and DOs can order and interpret laboratory tests. So we can't really even get off the ground. If a lab test can't be ordered, and you have to be a doctor to order the lab test. They're the only ones who can diagnose thyroid disorders and the only ones who can prescribe and adjust those medical medications that might be required based on their understanding of these lab tests. What are the problems of not getting this testing done? What are the problems of inadequate treatment? Prescribing psychotropics without testing thyroid can lead to basically a great deal of sorrow and distress for a patient, because they'll be getting medications which are off target from what they really need. They may need antidepressants too, but their basic medical condition that's the foundation of their problem is not being addressed. So an example, treating hypothyroidism-induced depression with an SSRI, that's basically a type of antidepressant, can delay or even prevent appropriate thyroid hormone replacement therapy because the person is told, oh, you have depressive disorder, so I'm going to treat you with this antidepressant medication. And then when it doesn't work, or it only works partially, and the person still feels very poorly because their underlying medical condition isn't treated, then you run into quite a devastating situation. Now let's talk a little bit about how to get this done. So it involves our two organizations of physicians. The Hawaii Medical Association is organization, is the district branch of the American Medical Association, and is available for all doctors in our state. The Hawaii Psychiatric Medical Association, or HMA, is the district branch of the American Psychiatric Association, and it's available for all psychiatrists in our state. So these two organizations are going to work together to make this happen. There's going to be a plan to organize and disseminate information and education and reminders that this testing is required. So thyroid screening for patients with new onset depression, anxiety, or cognitive symptoms will be required. Screening includes not just testing. The testing is required in the Senate concurrent resolution is crucial, but the physician has to have clinical awareness. If the patient's complaining of dry skin, brittle hair, slowed metabolism, cold intolerance, and other symptoms of hypothyroidism, it needs to trigger their ancient memory from medical school. Oh, we may be dealing with hypothyroidism. So that's what I'm saying. Screening is not just labs. We're not treating labs, but we're using labs as detectors to help us hone in on things we might otherwise miss. And also, people treating depression will collaborate with endocrinologists when consultation is needed. Because treating a thyroid condition is generally done by an endocrinologist and internist. Certainly, they treat plenty of thyroid conditions. Other practitioners treat them, but when there's concern about a confusing picture or the psychiatrist who's not an expert in thyroid disorders is not sure, they would consult with an internist or endocrinologist. So addressing potential barriers, we plan to develop an educational module and training for not just HMA members and HPMA members, but for physicians in our state in general. We could probably consult with the Hawaii Medical Board on the issue. And the other thing that we need to be sure to do is to make sure that access to lab testing is available even in underserved areas, and that there's no issues with insurance covering it, which I wouldn't anticipate. So the HMA and HPMA will be convening a roundtable with stakeholders. The HPMA will draft a protocol and meet with HMA leadership to ensure it meets all the requirements of our Senate concurrent resolution, and also ensure that the guidelines align with best practices in medicine. So using the expertise of psychiatrists, primary care physicians, and endocrinologists, and reinforcing that only medical doctors and DOs have comprehensive training needed to lead these efforts. So our two take-home points are establishing the protocol for thyroid function testing before prescribing psychotropics is critical for accurate diagnosis and effective treatment of depression. And only physicians have the qualifications to ensure these protocols are properly developed and implemented. Thank you. And happy to take any questions.
I have a question, sir.
Yes, ma'am.
Aren't psychiatrists medical doctors?
Yes,
So the psychiatrist, being a medical doctor, can order this test?
absolutely. Can and should.
Please feel free to engage, ask any questions, make any comments.
Comments or any feedback is appreciated. We'll be working on developing this protocol. It's rather straightforward what the goal is, but I'm happy to take any sort of feedback would be helpful.
After the protocols are established, can we get a copy of it?
I don't see why not.
But I would anticipate that we'll do something public again. That seems to be the way both the Psychiatric Association and the Medical Association like to operate and try to be as kind of public and transparent as possible.
Thank you. I believe your talk established exactly what's going on in this state and how we can help those amongst us that have not gotten the treatment that they deserve, and that is very helpful to them. And I'm of the opinion it's going to save a lot of lives. And there are a lot of people, I believe, in our judicial system that are there because this aggravates whatever other situation that they have. And is there anything we can do to help and assist? Would be more than happy to do so.
Thank you. Yes, ma'am.
I was wondering also with that said, thank you for this presentation. It's really, really valuable for clients who are receiving psychotherapy at the meantime. With this information, MFTs and psychologists will be able to refer them back to get lab tests if that so-called appear into the session. Because when they come in, we do not necessarily have all those medical records and stuff like that. Will this information be available to psychotherapists in our island?
I think that's a great idea.
Yeah, I think it will be very valuable. Like I've worked in addiction, I've worked in many different levels of psychotherapy, serving our community. And my interest just heightened. This makes sense because the first thing I asked them is, when was the last time you saw a doctor? And I think having this information available to therapists who are working with our community will be very valuable.
I think that's a great point. I think it should be disseminated to people who are practicing psychotherapy. Not that everybody should be referred, but for the therapist's awareness,
Correct.
because they might see things in a different light. And same thing, I think it should be disseminated to the medical staff in our, it's not called public safety. What's the division now over, say, OCCC? Is it
Oh,
the
the law enforcement or something? or-
They have a new department.
Yeah, right,
sorry.
right, they split it.
Because I've worked at OCCC for 4 years, but I think you made an excellent point about people in the justice system. Now they do plenty of medical screening, but I still think it'd be good for doctors and psychiatrists in our correctional system to be aware of this as well. I think that's an excellent point.
And usually when people go for their annual physicals, they have a blood test that tests for, many things. But this thyroid could be added to that.
Well, it is part of the regular medical screening exam. Oh, it's not? Well, it should be. The other problem, though, is unfortunately for a lot of our population who don't get an annual physical exam, who are homeless or addicted to methamphetamine, those people aren't getting any of this sort of care. So this would be important. When I also worked at Queens in the psychiatric emergency department and would see those patients frequently, but there would be a lot of problems already from malnutrition, which can also result in vitamin deficiencies that cause depression as well. But I think if thyroid function tests, I'm just thinking maybe because of my age, when I go to my doctor, I go every 6 months actually, but he always checks my thyroid. But if it's not a routine part of screening, it should be.
Can you make that recommendation?
I don't know. I know I can make it for psychiatrists, but I'm not sure I can make it for the entire medical community.
Dr. Tensal, do you know the protocol for that? Making additional recommendations for certain tests to be included?
So I'm hearing several conversations go on recognizing that something needs to be done. Meaning in terms of screening. I'm hearing asking whether or not it can be screened on a regular basis and whether it's not. And what actually impedes it from being screened on a regular basis is your insurance. It's not considered something that's automatically run. So that means it's something that needs to be screened for. And in a good annual, yes, it is something that you probably would pick up by speaking to the patient, they probably reflect with you that they're either having fatigue or any of the symptoms that you mentioned. The issue is it's competing with many other screens that have to get done in that small amount of time. So while in theory, yes, absolutely comprehensive between a patient that you see on a regular basis, it should kind of percolate up, but it is competing with a lot of other screens that need to get done.
But when I contacted clinical labs, they said the cost for it is $58.
Well, $58 is nothing
Just
for
for-
some families and a big deal for
But
others.
for the insurance companies, just think of how much it costs for one day of acute psychiatric care at the hospital.
No, you're not getting an argument. from me.
Right.
I'm trying to thrust you into the reality of my day to day.
Yeah.
And in my
58, I
day to
mean-
day, it becomes, when you try to then operationalize this, given that we all are not under the same insurance company, you can run into one insurance company, it can go under the other one, you have to argue. And so that you now have to distinguish not just uniform screening, but also the fact that it is not getting buttress against uniform insurance and benefits. And quite often, individuals don't know what benefits they have. So what physicians tend to do is they sort of practice to the middle. And then you capture patients as they come through when they have unique complaints. Do you see what I mean? So I definitely, I'm not arguing. I'm just saying that's why it's not automatically done, because
But
every
I think that those are all excellent points for this SCR. I think it might be important to touch base with our insurance industry and make sure that these tests are going to be covered and that we're not running into any different.
And that's such an excellent point. You see what I mean? To get it covered more universally there, because otherwise it's a strict checkbox on whether or not it will be a covered.
So
Okay, so how do we do this? You do this, we do this?
well, we would just contact the HMA or HPMA would make it part of our task list to contact, say, HMSA and the other major carriers and make sure that this isn't going to be an issue.
Okay, also with this, the people that have welfare, they have a different insurance.
Ohana Care.
Will the state, can you contact the state and ask them to participate?
We would contact, I believe it's Ohana Care, and we would just check with them.
Check with our MedQuest office.
Medicaid.
Yeah. MedQuest for Hawaii. Yeah. So a couple of things that came in on the Q&A. Senator Sam Buenaventura said the name of that department is Department of Corrections and
Oh,
Rehabilitation.
that's right. Thank you, Senator.
Okay, so
Thank you. I apologize. Thank you very much.
we're not on the tip of our tongue yet. And then one question that did come in is what are some of the other psychiatric illnesses that may be attributed to thyroid dysfunction?
Well, I think the main ones are anxiety, depressive disorders, and bipolar mania. There's something called an old term, myxedema madness. So myxedema was a condition of severe hypothyroidism, but the person would present in a psychotic state, but would have very obvious signs and symptoms. Myxedema is a form of advanced hypothyroidism. Those are the main ones.
How do we get the state hospital and other organizations that treat psychiatric people to have a thyroid testing went upon admission?
Well, the state hospital, the patients do get comprehensive labs and physical examinations, and the same on Kekela and in the psychiatric emergency room at Queens. I don't have that much familiarity, but I think the standard is the same at Castle. So we would check on their standards and practices. We would contact those administrators or medical directors of those facilities and just verify that.
You're going to do this?
That could be part of our plan. If it were my assignment to do, I'd be happy to do, but I'm happy to include it in the plan, and I think that's a good addition.
Thank you.
Dr. Busch, Thank you, sir, for that. And I have to say, coming from a family where everyone is some form of doctor, I understand that the reticency that could be there for HMA or medical people to take direction on protocols from the legislature with good reason. And I greatly appreciate that the actions you suggested with HMA and HPMA really seem to honor SCR 34 and really do a good job at it. I'm just thrilled to hear the open-mindedness and I'm grateful for this attitude that could help a lot of people.
Yeah, thank you. I felt like it was certainly a constructive suggestion, and if the legislature feels it's this important to pass an SCR, then it definitely requires our attention and action.
Well, thank you. As a legislator, I appreciate your feeling that way because most people look at our HCRs and SCRs and go, whatever, we'll get to it. So thank you for taking it seriously. Also, Dr. Busch, thank you for the presentation. I'm also a parent of a child with hypothyroidism who has suffered with severe psychosis, complete with auditory and all kinds of hallucinations, just extremely severe. So thank you for looking into this. Is there any estimate about how many, I know you focus quite a bit on depression. Is there any guesstimate on how many people may suffer with some sort of thyroid psychosis disorder in Hawaii? Is there any idea?
No, but I'd be happy to look into it. Epidemiology is one of my areas of interest, and I also have a Master of Public Health. And I'd be happy to investigate that and let you know.
Thank you. I'm curious. Thank you.
It's an interesting question.
Let me.
Yeah, you have some
ask
questions on there.
Right, exactly. So another question to follow was, how do the meds affect thyroid function?
Well, okay, by meds, I'm gonna assume psychiatric medications. So most psychiatric, that's a great question. Most psychiatric medications do not affect thyroid function, but one in particular can have a toxic effect on the thyroid gland and cause severe difficulties. So when it's administered, the medication is lithium. When it's administered, thyroid function is checked regularly. And if it starts off normal, and the lithium's administered, and then the thyroid function becomes diminished in any way, the medicine is discontinued. So there's one psychiatric medication that's notorious for its potentially toxic effect. The problem with lithium is it's a pretty good medication. It's been around for 5,000 years. Used to be in the soft drinks in Mexico. But in the doses given for psychiatric disorders, bipolar disorder, it can have a toxic effect on the thyroid and kidneys, so those functions monitored. The other medications, I'm not aware of any toxic effects or effects that they may cause on the thyroid.
Okay, two other questions came in. So it will be part of prior authorization before approving antidepressants that thyroid testing be done?
Bad idea.
Let me put it this way, we'll work diligently to enforce it as a standard of care.
That's what you mean.
We can't make a prior authorization as a term for the insurance, but we can certainly recommend some sort of assessment of that it's being done regularly. Now that the Hawaii Medical Board is the proper organization to monitor how physicians adhere to the standard of care. But we can certainly suggest that this become part of the standard of care for the prescription of psychiatric medications in our state.
And next question, how about making sure that nurses with prescribing abilities are trained, especially since they are relied on heavily by houseless providers?
That's an excellent question. Unfortunately, it's a little out of my jurisdiction, so to speak. I don't really have, unless one of those practitioners is under my supervision, I don't have any, and the HPMA doesn't have the authority to regulate nursing practice. So we can recommend this as a general standard for psychiatrists and physicians. But I'm not sure how to answer the question regarding nurses unless those nurses are practicing under the supervision of a physician. Then they would be able to have the impact that you're suggesting.
Can we get some kind of notification to like lungs and people, organizations that dispense these drugs, that if lithium is being provided to a person taking psychiatric medicine, that they get some kind of notice that this is gonna kill you or turn you into a vegetable?
It's already, I think, the problem is when you get your medication, even, Advil or Tylenol, you do have a long list of potential side effects. When you hear about them on TV, they read that long list of potential side effects. So they do provide all those potential side effects, especially with medications like lithium that can cause that. So that's already being done.
What can we do to help the homeless? How can the homeless get involved in getting some kind of help? And the reason I'm asking is, I often see bag ladies walking around downtown where they have clothes on after clothes, and I mean, they're walking around like they're in Alaska. And it didn't click to me until my daughter started doing it at home. I called her endocrinologist. She said the numbers are off. In 2 days, this was over. I didn't address it as being having anything to do with that, but there's so much of it.
Yeah, what you're referring to there is a public health initiative where people would go and interact directly or provide health information. So health promotion with the homeless population, waiting for them to come into the Queen's emergency room in a horrible state will not help with the question you're asking, which is what can we do to improve their health status? So more active efforts to disseminate information. A lot. When I first moved here in 2019, I worked in the H4 clinic, the Hawaii Homeless Healthcare Hui. It was a walk-in clinic for medical and psychiatric conditions. Dr. Landis Lum was the medical doctor there. And a lot of people who were houseless and homeless have cell phones. So there's ways to disseminate and educate the homeless population. A certain percent are in a very poor condition and need more structured help. One suggestion I have in the papers, I think you recently read about that, Maho Farms having a grant to develop more housing. And at the Hawaii State Hospital, apparently many years ago, there was a low E for the patients to work in as a form of health and rehabilitation. So that those sorts of ideas to assist people who are houseless in Hawaii, I feel would be beneficial. And I think I'm straying a little from our topic and getting into something of personal interest. So I apologize if I'm off task here, just trying to answer your question as succinctly as I can.
No, I thought that was a great presentation. Thank you. I mean, because I mean, we were involved in the beginning. So, right, I'm the director of the Disability Rights Center, and Pauline is on my board.
Right.
And she had an experience with her daughter, which is I guess somewhat similar to what happened with Representative Amato. And so she brought the issue to me and, what can we do about it? And I'm a lawyer, I'm not a doctor, right? But so I know enough to know that you can't necessarily mandate medical practice, and nobody was trying to do that. But we thought, well, why not go to the legislature and see if we could get some discussion going, have some hearings, and we connected up with Representative Amato, and of course here we are. And Mark and I had dealt with this issue during the session, but it sounds like you're you're really agreeing with the premise of the resolution, which is very heartwarming to hear, because I'm not sure we heard from the Psychiatric Association during the session.
Well, I did write some testimony, but for some reason it didn't
get in.
register. But I think anything that can be done to help improve our practice standards, and this is a good example, is worth pursuing aggressively.
Yeah, no,
We
we
have the best life expectancy of any state in our country, and a much better life expectancy than most of the world. And doing things like this can only improve our quality and life expectancy here.
Life expectancy 57 years?
Well, no, our life expectancy in
No, for the mentally ill.
53. For homeless, mentally ill people is 53,
Right.
but for the general population in our state, it's 83.
Mhm.
But unfortunately, if you're a homeless person with a severe psychiatric disorder, your life expectancy is closer to 53.
But so I'm delighted that you really seem to be on board with this and you agree. I mean, because what we heard during the session was that when we talked with different psychiatrists was that everybody seemed to agree that this was a good idea and that a lot of doctors do it. So I guess some doctors would routinely do thyroid testing if there were symptoms of mental health issues, but I guess not everybody does. And then the question was, how do you reach those other people, which I guess is one of the things that you'd want to talk to. It also seems to me that there's two different issues. This issue about the routine medical exam, insurance-wise, I would think is a different issue, because what we're talking about is somebody who comes in with symptoms. And so the idea is that if you appear to be if you appear to have a mental health issue, let's test the thyroid before we give you psych meds. Versus, I mean, when I go for my annual physical, I don't know, maybe they do test they draw my blood, they test 100 different things. Maybe thyroid's in there, maybe it's not. But I can see where the insurance company might be saying, unless you have some reason to do the thyroid test, then right. Whereas I would imagine that if somebody presents with a mental health issue, then getting insurance coverage for the thyroid test would not be as problematic.
It actually isn't. I think that's the difference. What you were suggesting
Exactly.
is universal screening, which
Right.
would be very costly. So typically what it is it's carved out that there should be some sort of symptom. What I'm hearing from you is, in addition to the traditional symptoms, can we add the possibility of adding a psychotropic drug as not necessarily a symptom, but one of the additional indications for ordering a TSH?
Well, when someone has depression, though, the insurance will cover a battery of lab tests, because hypothyroidism is, as I mentioned, is one of a number of medical illnesses that can cause depression. Certain kinds of vitamin deficiencies and other medical conditions that cause depression. The insurance will cover lab screening then. It's just developing these prompts and working on raising our standards so that people have this awareness and pursue doing this.
So if many doctors do the screening in that situation, but some don't, so then the challenge is how do you then reach those that don't typically incorporate it? That's what you're trying to work on.
Yeah.
CMEs.
Right.
For instance, someone could go to the doctors with severe acne, and it's caused by the thyroid, and it's not caused by, there's nothing you can do to treat it topically, or even a diet's not going to change it because it's caused by the thyroid. So there are simple things that can be fixed easily. But it doesn't present as a psychiatric problem or some other kind of, but it's caused by the thyroid.
Any other questions from the
Nope,
listeners?
right now, we have 5 minutes, but we can go ahead and bring this to a close because we'll have an opportunity
If
here.
there's no other questions.
Right.
I just wanted to make sure we were
Sure.
getting everything
Mhm.
answered as best I can.
We're closed.
Okay.
Nothing else.
Either?
Thank you.
Okay, there's,
Yep,
all right.
thank you. It appears that
So I'm going to go ahead and do a little formal closing. I just want to take a moment to thank everyone for joining us for this conversations at HMA. We want to thank Dr. Gerald Busch, especially for his time in preparing this presentation, and for all of you making time to be here tonight, especially our elected officials and other healthcare professionals. We know you have your choice of activities, and so we appreciate you making time this evening. This program and the attachments will be available to the public by early next week via our HMA YouTube channel. And will be also accessible directly from the HMA website as well as the YouTube site itself. Mahalo. Have a great weekend.
Thank you.